Hey, good morning, everybody. Welcome to the next iteration of Hanging with Dr. Cooper. I have a fantastic guest with me today, Dr. Tara Hrobowski. And as you all know, we don't do long, drawn-out bio reading and advertisement on Hanging with Dr. Cooper. We want people to tell their story. Everybody has a story. So here we go. Dr. Tara Hrobowski, a.k.a. T-Rob. Named by Dr. Cooper, I guess. I'm sure somebody else calls you that. Yeah. But anyway, all right, Dr. Hrobowski, tell us a little bit about yourself.
So much to tell. So,
absolutely.
All right, I'm originally from the west suburbs of Chicago. Around age 6, my parents divorced. We did a lot of moving around. We ended up in New York, so I lived in Brooklyn for about a year. And then I actually ended up in Arkansas. Pine Bluff, Arkansas. Yes.
Oh, Pine Bluff. My wife's people are from Pine Bluff. Yeah.
Everybody's people are from Pine Bluff.
Yeah. How about that? Yeah.
So then from Pine Bluff, I went to a boarding school in Hot Springs. It was actually chartered by Bill Clinton. So
wow, how about that?
Yeah, it was awesome. And while I was actually, it's called the Arkansas School for Math and Science. So while I was there, one of my mentors was Jocelyn Elders, right?
Wow.
Exactly.
Yeah, former Surgeon General, for those that don't know. Yeah.
Exactly. So that was an amazing experience. And so after high school, though, I went back to Chicago. So I went to the University of Chicago for undergrad. Okay. After graduation, I actually ended up in Atlanta. Okay. So I was working for the CDC and Emory University School of Medicine in the Department of Infectious Diseases. So it's so funny. I always tell people, I don't know how the hell I ended up as a cardiologist because I thought I was going to cure some kind of infectious disease.
Interesting. Yeah, okay. Sure. Yeah.
Some of my research was actually on gonorrhea. Very interesting. Important. Right.
Interesting. Public health. And no doubt about it. Yeah, still a public health issue.
It's very important. So I made it.
Yes.
Okay. So then I was like, okay, I love being in the lab. I love research, but I was like, I can't do this. I have to go. I have to talk to people. I can't just be inoculating Petri dishes all day. So I have to go talk to people. So that's when I decided to go to medical school. So I went to medical school at Indiana University, did my residency back at Rush University Medical Center back in Chicago. After that,
you like Chicago.
I like Chicago. I just don't like the weather, man. If I could put this Florida weather, Chicago, then you have it. So Chicago for residency. I was a hospitalist for a year actually before cardiology fellowship because, like I said, I switched gears, and nobody thought I would ever get a cardiology fellowship, right? Because typically, my classmates, their mamas were cardiologists, their daddies, their granddaddies, so they had and it's so competitive. They're like, you'll never. I ended up with like 10 interviews. So I was like, boop, there you go.
Wow, there you go.
Right. So I ended up actually in Detroit at Henry Ford Heart and Vascular Institute. So I've been all around the Midwest, for the most part. So Detroit has a very special place in my heart because that's where I met my husband.
How about that?
Yes. So, and then after I did my general cardiology fellowship, in advanced heart failure. I was Henry Ford's first advanced heart failure transplant fellow. And then, so then I went back to Atlanta. My sister, it's funny, I had my pen to the paper with the contract in Indianapolis, go back to Indy. And my sister was like, wait. Piedmont and Buckhead is hiring. And I was like, okay.
How about that?
So I ended up back in Atlanta. I was at Piedmont for 5 years. One of my partners that I worked with at Piedmont had come to Florida in Largo and called me up and was like, Tara, I'm starting a program, an LVAD transplant program. What do you want to do? And I was like, I'm up. I'm underpaid anyway. Let me get out of here.
How about that?
Exactly.
Fantastic. Love it, love it, love it. So for you all that don't know, I am talking to Dr. Tara Hrobowski, aka T-Rob to me. She is a transplant heart failure expert. She is joining me live today on Hanging with Dr. Cooper from Tampa, Florida, home of the Super Bowl, where the Chiefs will prevail later today and take home their second Super Bowl in a row. I'm absolutely sure that. I am in Kansas City, where it's freezing cold, and they're down here blocking off the streets, trying to keep people from going crazy here a little bit too early in the day. But we're going to have some fun. So we're talking to Dr. The first segment on Hanging with Dr. Cooper is always for the younger people who are out there listening. And I want them to be able to reach out. I don't know. You said you had Dr. Elders, Jocelyn Elders, who's former Surgeon General, who was a mentor to you. That's fantastic. I had mentors as well. But I want the young people who tune in here to see us, okay, to see young African-American physicians and other physicians. It doesn't matter if you're black or white, but people who really are just real people who reach out and touch and reach back and pull somebody else up. But you mentioned a little bit about the infectious disease thing and then cardiology. So what was about the heart that kind of got you interested in cardiology? Where did that transition happen?
The transition happened, I will never forget. I know the day, the time. I remember I was on call in the CCU. So let me give you a little bit of background. I hated cardiology in medical school. And I think this is so sad because your professors in school can really, divert you in one way or the other, especially if they're terrible. So in medical school, I didn't think I had very good cardiology training. Okay, so at least let me say this, in the first 2 years when it's just mostly academics, you're not actually rounding in the hospital yet. And so it was just hard to me. I was like, this is, okay, I just want to, do well enough to get through this. And then I hope I never see cardiology ever again. But in residency, I was in the cardiac care unit and it was a horrible night. And I remember crying in the bathroom, like crying in the bathroom. But afterwards, I was just like, I want to come back. I want to do well with this. And then I had very supportive staff, like very supportive attendings and things like that. So I felt so blessed because it really changed the course of my life. That moment changed. It made me who I am right now. So yeah, made
you a fighter because it sounds like you had a horrible time. You like the hell with that. I can do this. Yeah. Yeah. I recall very clearly when I was here. I went to medical school here in Kansas City at the University of Missouri in Kansas City, and I recall very, very specifically one night I was on a rotation with a group of cardiac surgeons. Actually, one of those cardiac surgeons now, 30 years later, is now my partner. Believe it or not. And actually, I was in on his very first case, Jeff Kramer, that he did as an attending. I won't tell you what year that was, but it was a long time ago. But interesting. I remember coming in one night and talk about having these moments. I remember coming into the hospital one night and getting called in as a student. They did that back in those days. You had to come in and help them out. And I'll never forget in the middle of that case, it's probably 1:30 and I was tired. And, I really didn't want to be. I said, why am I here? Of all people, I'm a student. I don't know a damn thing. What am I doing? But I was really very thankful that I had that opportunity because it was moments like that really made me the surgeon and the doctor that I am today. But during that procedure, I just remember saying to myself, I can do this. I said, this is not that hard. It was just like that moment of like, because before that, it was very surreal. It was kind of like, oh, this can't be real. I mean, this is amazing. They're stopping the heart. They're, slapping the heart. They're not literally slapping the heart around, but I'm like, I was just, in awe. But then something hit me and it said, Coop, you can do this. I mean, this is, this is nothing magic to it. It's just, you got to set your mind to it and get it right. Well, anyway, Dr. Hrobowski, let's move on now and talk a little bit about congestive heart failure. This is Heart Month. You're my first guest. Guess who's coming on with me next week?
Who?
Dr. Dave Montgomery, your good friend Dave Montgomery.
Yes,
Yeah, my man. That's my cardiologist. My heart's good, but I have a real bad family history, so he checks me out from time to time. But he's coming on with me next week. But let's talk about congestive heart failure. One of the things, and one of the reasons I wanted to touch on this is I get oftentimes people say, well, and you've had this experience. Well, the doctor told me I got congestive heart failure. The doctor told me I got a heart murmur. I'm like, but you need to be asking the other question, which is why? What caused that? Why is your heart? And then it's oftentimes one of those things where we just accept that as the end game. And I'm like, no. You need to understand so much more about this so-called. You say you have congestive heart failure. You say you have a heart murmur. What caused the murmur? What caused your heart failure? So give us a little bit of just an overview of what heart failure is, and how is it so pervasive in our society?
So heart failure is actually what is described as a complex clinical syndrome. Okay, so what happens is there's injury to your heart muscle for whatever reason. Okay, maybe it's a heart attack. Maybe, your heart got attacked by a virus, which I'm sure we'll talk about a little bit more. And
it may have gotten attacked by us by eating fried chicken and all this other stuff too.
And we'll talk about that. But what happens is when that injury occurs, there are adaptive features or adaptive things that happen. The problem is that those adaptive things are good in the short term. But in the long term, they become maladaptive, okay? So those things that help you increase cardiac output because of your injury soon become deleterious, okay? And so then that's what leads to the clinical symptoms of heart failure. So you retain water, so that's why you see patients with, swelling in their legs, things like that, or patients that can't lay down flat. That's because they have fluid in their lungs, for example. Or even you'll see some people who have abdominal bloating, things like that. So you can, there are some patients that never get lower extremity edema or they get never lower extremity swelling. They'll always kind of carry that fluid in their bellies. Mm-hmm, mm-hmm. But the reason why people get heart failure, right, is because of risk factors, okay? Risk factors that they haven't controlled. So uncontrolled hypertension, diabetes. So the glucose intolerance can become deleterious to your heart pumping function. And so can obesity. So excess adipose tissue is actually deleterious to your heart pumping function as well. So these are some of the things that, there are modifiable risk factors and there are non-modifiable risk factors. For example, what you just said, well, he checks you regularly because of that non-modifiable risk factor of your parents, having heart disease and things like that. So what I always tell my patients, let's focus on the things we can modify. I can't modify what my parents are. It's just who they are. Right. But we can modify the fact that you don't exercise. We can modify the fact that you go to Publix every other day and get that good fried chicken. We can modify those things. Now I shout out to Publix, okay? But these are things that we can modify. We can modify how much alcohol you drink. I'll never tell anyone to stop drinking alcohol. I'm sorry. I just but,
no confessions here. No confessions. All right.
I'm one of those people. I'll never tell my patients to do something that I'm not going to do. I'm never going to tell you, because let me tell you this though. I felt like such a hypocrite at one point because I was telling my patients to exercise, and I was like, Tara, you know what? You weren't exercising. So it really bothered me. And I was like, okay, this is a practice what you preach. If I'm going to tell them to do it, then this is what I need to do.
Yeah. Oh, let me ask you this. I am oftentimes a little dismayed when I see patients. I see patients in my office, and I think heart failure, to be honest with you, in my opinion, is one of the most poorly treated problems in all of cardiovascular medicine. Now, I don't mean that the therapy isn't there, but I just think that too often patients come to me and they need surgery, but you look at them and you're like, okay, so how did we get here? You've been years and years and years of an ejection fraction that, and people, so we don't, and I told Tara, we're not going to do the things you don't understand. So ejection fraction is just the amount of blood that comes in the heart that gets pumped out with every squeeze, okay? And so normal is somewhere between 50 and 60%, 55, 65%, meaning of the volume. And it's all subjective. It's a doctor looking at an echocardiogram, an ultrasound of the heart, telling us how much is getting pumped out with every beat. But I'm often dismayed by that because, and then I'll say, well, they told me a few years ago I had heart failure. Well, did you get the echocardiogram? Did you get the stress test? I mean, that just bothers me that we see that. I see that as a surgeon too often. Go ahead. So
here's the thing, and it's two words: clinical inertia, and it happens all too often with us. Okay. So a personal story. My husband probably will kill me, but so he goes to the dentist, and they're like, "Sir, you need to leave." And he's like, "Okay, well, what's going on? Your blood pressure is 207 over 100."
Oh my God! Wow.
126. That's stop. Okay. So he calls me at work. Well, clearly, I've heard bad things from people, but it was like instant tears came to me. Okay. Because I was just like, number one, this is my love. Like, how did I it was almost like, how did I let it happen? Great. But here's the thing. Come to find out, 2 years ago, a physician told him that his blood pressure was high and didn't put him on any medication. That's crazy to me. It was 168 back then. There is no way this whole white coat, whatever, your blood pressure should never be that. Okay? Nobody should be making you that anxious. You know what I mean? So it was just very disappointing because this could have been handled several years ago and we wouldn't be sitting right here.
Yeah. Yeah. I will tell you that I've seen that so much. And so the purpose of this conversation for the audience, and just for those of you who are just joining me, thank you so much, Glo Brooks, my mother-in-law, Bessie Webb, Brenda Walker, from my homegirl, Felicia Lewis. I'm going to try to call some people out. Mimi, I see you down there. Mimi was one of my surgical techs in Atlanta. JC, Jennifer Christian. Hey, how you doing? I am on with Dr. Tara Hrobowski. Known to me, aka T. Rob. She is a fantastic cardiologist as her background, but her area of expertise is in heart failure and transplantation. And we're talking about congestive heart failure. Hey, Rochelle, how you doing? Dr. Harvey, Kyra Harvey. You know Kyra, T. Rob. Say hello to Kyra. You got our people checking in. How about that?
Yes.
So one of the things about that, and the reason why we're having this conversation, is I want people who are listening to us to be assertive when you go to doctors. And you and I are here saying, hey, it ain't right that your legs swell like that. No. That's just not, you need to be asking. It's not that you have bad veins. You may, but that's the bad veins in your legs aren't going to kill you. But if it happens to be that your heart, that you're retaining fluid because of a heart issue or a kidney problem, that can kill you. And so you really need to be very, very, extremely assertive. One of the things I wanted to go back to the high blood pressure thing, because I think that's one thing that I see that is a very, very common sort of overlooked thing. And we want to drill down on this, especially for African American men. I lost a good friend, frat brother, to congestive heart failure last year. God rest his soul, Devery Freeman, a great brother, and he was taken care of by our friend Brian Howard up at Wellstar.
I know, Brian.
And yeah, it took great care of him, man. But he what his underlying, he was overweight, but his underlying issue was this. In addition to all of the other risk factors, being overweight, hypertension, you layer on top of that. We started going back through it. Brian called me, and Brian said, after I sent him to Brian, I had already left Wellstar at that point, but I said, Brian, he said, cool. He said, man, let me tell you something. You saved this guy's life. Now he passed away last year, but he said, man, he was literally completely neglected from a heart failure treatment perspective for about 5 or 6 years. We started going back, and I was like, what are we doing with these medicines? And I'm being very critical of our healthcare system in this case, and the physician who was taking care of him. But the sad piece and the piece for the audience is this: do not accept, if you're not feeling better, you need to keep pushing this issue. What do you think about that, T-Rob?
So, no, again, like I said, it goes back to this inertia, this not pushing forward, not being aggressive.
Mm-hmm.
So it's funny. I had a conversation with a patient, and I think sometimes I can't sugarcoat things. Okay. Heart failure is a 100% fatal disease. It is a progressive disease. You can stabilize heart failure, but you will never cure heart failure unless you get a transplant. Okay. And sometimes when you speak to certain patients, I think they hear the negativity, that, oh, it's fatal, this kind of thing. But I think it's our job to go through the entire spectrum. So you're feeling this way today, right? You have the swelling in your legs. This is what we're going to do. This is why I'm putting you on medication. Because I think a lot of times as a heart failure specialist, we have guideline-directed medical therapy, right? We have evidence-based therapy. You're going to be on a lot of medications, just period, point blank. The problem comes when the physician doesn't say, well, this is why you're taking this medication. Because what will happen is that person will go home, talk to their wife, their cousin, little Ray up the street, and they'll say, well, you're on too many medicines.
Mm-hmm.
And so that person is like, oh, well, my doctor told me I need to take this, but then they can't say why. So they'll end up probably not taking it. So I think it goes back to what you said, in the sense we as the patient have to ask more questions, right? But I think it's our responsibility as physicians to educate. I spend most of my time in a clinic visit talking, not even touching, but talking.
Right.
This is why I'm putting you on this medication. I know your blood pressure is okay, but the etiology or the cause of heart failure is, because the hormones are going, your hormones are going crazy. Your fight or flight is on all the time. And that's what gives you the symptoms of heart failure. So that's why I'm putting you on this medication and this medication and 2 more medications, right? I think at that point, once they're able to explain to other people, hey, my doctor knows what she's doing. This is the reason why she's putting me on these medications. I think that's when, as physicians, we'll be satisfied with our patients' compliance.
Yeah, I get it. Good morning. I see you out there, Milton Little, Sharon Allen, Freddie, Uncle Freddie, Scott checking in, Quan, my project manager, CTO for Prime Health. I see y'all checking in. I'm on with Dr. Tara Hrobowski. She is coming to us live from Tampa, home of the Super Bowl today. She's hanging with Dr. Cooper, and we're talking about congestive heart failure. We talked a little bit about some of the etiology of this, and our audience is very smart. I think healthcare has got to get away from this. We need to educate, please. These people out here are smarter than you and I. What we got to do, though, however, is it's on us now to engender trust. And Jane and I talked about this whole idea a couple of weeks ago when Dr. Jane Middlebrooks, your friend Jane, was on. And we talked a little bit about, this is not a educating people problem about this vaccine. This is you got a healthcare system that people have seen do some really bad things to people.
Exactly.
So it is on us. It is on us as a healthcare system. And I want to thank my good brother, Ralph Dickerson, who brought this up on a text stream with a group of us a while back. Get away from this. We need to educate. No. People are very smart, but what they have seen is a system that has a lot of issues that we got a great healthcare system. I'm not here to bash. So all my physician friends out there, don't get all your knickers in a twist. It's all good, but we do have some issues that we need to deal with when it comes to these issues. So let's talk a little bit about, so we have congestive heart failure. We talked about some of the causes, a heart attack. We talked about the high blood pressure. There are other things, your heart beating, atrial fibrillation, or your heart beating out of sync for long periods of time. Let's talk a little bit you mentioned some of the medications. Talk a little bit about this cardiorenal, and I'm not trying to use big words on that. That's just heart, kidney, sort of connection and this thing with the water retention in somebody who has heart failure, and talk a little bit about the medications and how what are you targeting when you're trying to treat somebody who has established congestive heart failure?
So specifically with regard to, you think about your heart as kind of the engine, right? So it's the center of everything, right? So if your heart isn't pumping properly, then you're not going to get proper blood flow to the rest of your body, right? So decreased blood flow to your kidneys, whether that's because of poor output, so just sheer, your pump is not getting blood there, or you could be so fluid overloaded that blood flow is not getting there. So the way that we address that, number one is, and we increase contractility, we increase that pumping function artificially with medications, of course, so that we literally push blood to the kidneys, okay? Well, then we have diuretics, so the medications that we prescribe to make patients, pee out more fluid so that it's easier for blood to get to the kidney. So that's the goal. You want better blood flow to the kidneys, whether that's by increasing contractility or decreasing perfusion pressure. So the pressure it takes to actually get to the kidneys. So that's kind of the interrelation between the heart and the kidney, but it goes for any organ system, right? So one of the main symptoms that I actually see when patients are going into like cardiogenic shock or an acute episode of a heart failure exacerbation is their mind. They get very confused, and some people, I'm just getting older, I can't, everything is fuzzy. No, you're not getting adequate blood flow to your brain, or they'll have cool extremities. It's like you're ice cold. It's warm outside. Why is that? Because you're not getting proper blood flow.
Cool, great. So now you talked about increasing contractility or the pumping function of the heart, and you're doing that by manipulating the blood pressure and the volume and trying to match those things up. One of the things that oftentimes I see people ask me about is, okay, well, why do y'all giving me this? I'm moving on to the beta blocker now. Why are you giving me this thing that's going to slow my heart down? And I read somewhere that it actually makes your heart weaker. Talk a little bit about that.
So it doesn't make your heart weaker. So when you are in heart failure, so you get an upregulation of those beta receptors. So that's why you have beta blockers, because again, that maladaptive to increase. So not to be technical, but okay, cardiac output is, heart rate, stroke volume, right? So but as you mentioned before, if your heart rate is too high, right? Then now you're using, or you're increasing the heart's O2 demand. So then it becomes a supply demand mismatch. Okay. So that's one of the reasons why you want to use a beta blocker, keep the heart rate lower, so you're expending less energy. Okay.
Got it.
Yeah, but to their defense, and probably what they may be describing or what they heard is, in an acute heart failure exacerbation, you need the heart rate to be higher in the short term, right? So that you can keep the cardiac output, you can keep that blood flow to the rest of your body. It's just that you can't keep it long term, the high heart rate long term. So that's why acutely, no, you wouldn't use a beta blocker. That would be the wrong thing to do.
Got it. Excellent.
But,
salt. Let's talk about that salt.
So let's be clear. There's honestly not a lot of like hardcore data with regard to sodium restrictions, to be perfectly honest. But it's something that I feel like is tangible for a lot of people.
Okay.
So I'm a big proponent of, hey, let's restrict, sodium, 2,000 milligrams, your fluid to 2 liters. Okay. Because I feel like that now you're putting the responsibility back. Okay. And those people who are diligent about that are going to be diligent about taking their medications. They're going to be probably more diligent about exercising and adhering to the other recommendations that you make. But again, in terms of, I know we all like clinical trials and, large studies and things like that, there aren't any.
Tara, talk a little bit about, and for those of you who just joined, that's my auntie, Doris Bacon. Hey, down from UAPB, by the way. Tara, we talked about that. Yeah, I saw my other aunt, Faye McIntosh Scott, on there as well. But and then, of course, my mother-in-law was here a little while ago also. But talk a little bit about, if you will, about exercise with heart failure. I believe, to be honest with you, I've seen one patient, operated on one person in my life, in my career. God, and Lord of mercy, that's not a lot. In my career, that I really believe had an exercise-induced cardiomyopathy. This gentleman was one of those super marathoners. He ran when I operated on him, he was in his, I think, early 70s. And he had been one of these lifelong super marathon. He would run these 100-mile races, had done some ridiculous number of Ironmans and all kinds of, and literally his heart was two to three times bigger than normal. Okay. But structurally it was fine. I ended up operating, I repaired his mitral valve for MR. He had a prolapse, but we got in there and blood pressure normal, everything, all things being equal, but this guy's heart was just, it was human. And I think it just dilated out over time from needing to it was just adapting. You talk about adapting to all of this training he was doing. But that's the really rare extreme where somebody's going to have a problem like that. So talk about somebody who's been diagnosed with congestive heart failure and their ability to exercise, and how do they monitor and keep tabs on that with their doctor?
So I am a very strong proponent of cardiac rehab, because I think a lot of times when patients hear, oh, I had heart failure, number one, your loved one is going to be like, oh my God, you can't do anything.
Right. Yep. There you go.
You can't cook, you can't clean, the wife is waiting on the husband hand and foot. And I'm just like, no, that's the opposite of what I want. So I think cardiac rehab, it's a structured program. There are medical professionals there, because I think, again, the patients too are a little bit intimidated, to work out, but they feel a lot more comfortable knowing, well, if I'm exercising, at least I know there's someone, here that can monitor my vitals and things like that. And if there's anything abnormal, I get reports from my patients that I send to cardiac rehab. So I'm able to see their progress, things that are going wrong, that kind of thing. So I think that just kind of eases their concerns, and actually eases some of mine as well. But it definitely gets people away from remaining sedentary.
Yeah, that's very interesting. You brought that up, because you and I kind of grew up in this. I grew up in southern Missouri. It's more southern than it is Midwestern, and very familiar with Arkansas and all of that. But we grew up in a place. I remember growing up, and the diabetics would be like, "Oh, he needs to eat so he can take his insulin." It's kind of like, wait a second, you putting all that crap in your body just so you can take a shot? Does that really make sense? And so, so that idea that you're talking about, you want to, you got heart failure, you need to sit on your butt, you need to get up, you need to get moving, you need to exercise. So that is extremely important. So all of you all, hey, I see my Aunt Betty, my Aunt Alma. I have to shout out to them. I'm gonna get in trouble if I don't recognize all the home folks coming in. Ron Freisen, I see you, my CMO, my Chief Marketing Officer, the person who got me here, Tashana Thompson, checking in. Al Glover, what's happening, man, over in Carolina. So the topic of I'm on with Dr. Tara Hrobowski. She is a transplant heart failure expert. She is in Largo, Florida. For all of y'all don't know, that's down near Tampa, and is one of the heart failure experts there at that hospital to take care of transplant patients and people with really severe cases of congestive heart failure. And that's what we're talking about today. Montez, I see you, my brother. Tell your wife, cardiologist, interventional cardiologist up in the DC area. We said hello. But topic of the day, I'm on with my friend, Dr. T-Rob, AKA topic of the day, COVID and the heart. T-Rob, hit me. I have seen some really bad hearts with COVID, and I mean really dramatic situations where, I'm looking at an echocardiogram from 2 weeks ago, and the heart's just pumping along just normally, and then less than 2 weeks later, this thing is twice as big as it was, or RV doesn't work, there's clots inside of it. What is going on with COVID in the heart?
And so, and that's the thing. So COVID in and of itself is just an inflammatory response just going crazy. Okay. And so what ends up happening is that inflammation recruits cells that then cause damage to not only the actual heart muscle, right? So there have been, cases of autopsy specimens that have actually identified actual virus particles. Mm-hmm. So it can directly invade the cardiac cells. It can invade the endothelial cells, right? Make them leaky, and that's how you get the pulmonary edema, right? Make the lung cells leaky. It ends up, you get increased formation of hyaluronic acid. So hyaluronic acid for your face is great, right?
Yeah.
When it's in your lungs,
hey, Tara, or if you like me, your bad knee.
when it's in your face, that's great because hyaluronic acid can actually hold 1,000 times its weight in water. So that's great. That's, women, we want to look plump and all that in the face. But again, you don't need that in your lungs, right?
That's right.
Again, it's that inflammation that can ultimately lead to scar. And so that's the biggest thing, the myocarditis, that I'm sure, people everywhere, even lay people probably know what myocarditis is at this point, because we saw the little young athlete that ended up collapsing.
Yeah, absolutely. Yeah.
He had COVID before, and then this was, several weeks and maybe even months down the line that he ended up collapsing. These scars can be foci or areas where you can form abnormal heart rhythms that can lead to what we call sudden cardiac death. Okay. Mm-hmm. So it's you really have to understand the fact, though, that just because you didn't get symptoms with your COVID doesn't mean that you didn't get the heart damage that went along with it.
Very good point. Very good point. Yeah, go ahead.
You have to be careful in making sure you're monitoring symptoms, things that don't seem right. Now I'm developing palpitations a little bit. That's something that you need to alert your physician, even your primary care physician. They can order an echocardiogram and they can look at to see if the heart muscle now looks thicker. They can do a cardiac MRI. I'm a big proponent of cardiac MRI because, it's like a one-stop shop, right? I can see scar, I can see how thick it is, I can see the function of the right ventricle. And going back to your point, the right, when COVID first hit us, so we were delayed. I work in Pinellas County. We were delayed in that county. Okay. But when we started seeing them, it was males in their 50s and they were coming in with right ventricular failure. We could never really identify why, but I think it was pulmonary emboli that just weren't detected on CT.
Mm-hmm. Yep.
So clot formation was a really huge deal. Clots that not only went to the lungs, but clots that went to the left ventricle that ended up going to the coronary arteries, leading to heart attacks. Attacks on
I've seen that. Mm-hmm.
Vessels that sit on top of the heart, so causing heart attacks, but even microvascular clots, that caused ischemia didn't necessarily lead to a heart attack, but patients were coming in with chest pain and their coronary angiogram was normal. I had actually quite a few Takasubos, the stress-induced cardiomyopathy. With women. So it was a lot of cardiac manifestations, and we're mostly known as a heart hospital. We do a lot of ECMO. We're ECMO heavy. So we were getting patients flown in. We had 8 machines, but ended up having 12 patients on ECMO. We just had to borrow, from other places. So
Got it. Good discussion here. I'm on with Dr. Tara Hrobowski, heart transplant and heart failure expert, joining us from Tampa, hanging with Dr. Cooper. T-Rob, known to me. You have to give a shout out to my Aunt Joyce and Uncle James there over on YouTube. Can't miss them, man. You can't miss them. I love my people. Kelly Campbell Hemphill, Essence Harris. Hey there, Essence. How you doing? Essence is a tremendous advocate for heart issues down in the New Orleans area. Kim Cole, I see you. Lady Phillips, Jetty Taylor, I see you. Jean Boshamer, I see you coming in. Shouting out to my people now. Bronwyn, how are you doing? Tabitha Tucker. I'm trying to get everybody in there. I can't. Hey, K. I see Bragg. How you doing? I see you checking in. So we talked about this COVID. One of the things that I have a friend of mine out in California got COVID early in March, T-Rob, and is still struggling with it now. But here's the interesting thing. Has gone in, I looked at his echo. The echocardiogram is normal. He has not had, formally has not had pulmonary function tests. But the echocardiogram pulmonary pressure seemed to be normal. There doesn't seem to be any evidence of pulmonary hypertension, but he can't breathe. I mean, he just has this, and I'm wondering if, because one of the things they didn't talk about on the echo was diastolic function. They didn't even mention it. And so I was thinking that maybe he's got a relaxation problem. I didn't see images, just a report. And so just talk a little bit about, I am also going to put this out there. I did a little call to action on LinkedIn the other day. We need to stop calling this long hauler syndrome. And the healthcare profession needs to give this a real name, whether it's going to be post-COVID syndrome or post-COVID recovery, whatever. But we need to start trying to define and categorize this. But talk a little bit about that. He just can't breathe, but everything. And he's got this sensation, I just can't seem to get enough. And he, will get cold when he tries to exercise and all this other stuff. Looks like somebody's in heart failure. Yeah.
Is that he gets symptoms the most when he tries to do stuff?
Yes.
So one of my other areas of interest is pulmonary hypertension. So you can have pulmonary hypertension that's exercise induced. So typically what I do for those patients who have exertional symptoms and there's nothing else that you can figure out about them, I'll just do an exercise right heart cath. I'll do a conversation and look at their pressures as they're exercising, as they're exerting themselves. But as you said, you'll notice those patients who have diastolic dysfunction or the kind of heart, which is still heart failure. Okay, so let's.
It is.
Can still have the same symptoms, even though the breathing function is normal. You can still have the same symptoms, and guess what? Mortality is still the same.
Yes.
Right?
Yes.
It doesn't matter whether it's a pumping problem or a filling up relaxation problem. It's still a problem. Okay. So what I would recommend for him is to go to a heart failure specialist, to be perfectly honest, or an interventional cardiologist that's hemodynamic savvy, and really take the time to do a really thorough exercise hemodynamic study. I would also recommend you could do a cardiopulmonary exercise test.
Okay. We rarely see that anymore. People used to do that all the time, and now it's like,
this is how I risk stratify my patients, and because your patients will come in and say, "Oh, I feel fine, Dr. Hrobowski. I'm good." Yeah. And you're like, okay, and you'll say, "How many floors are in your house?" 2. Well, when was the last time you went upstairs? Oh, a year and a half ago. It's like, okay, you're not fine. You're not fine. But it's a way to put, something objective and say, I'm not making this up. You really need some advanced heart failure therapies, because this is telling me objectively that your heart isn't providing enough circulation for the activities of your body.
Got it.
Yeah, but diastolic dysfunction, I think people kind of poo-poo it a little bit because we don't have the same kind of guideline-directed, medical therapy as we do for the pump when you have a pumping problem.
Yeah.
The way to treat the diastolic dysfunction is controlling, again, going back to risk factors, making sure blood pressure is controlled, making sure your fluid status is appropriate, things like that. But I would tell him, do not stop trying to figure out what the problem is.
Yeah, that was my thing. As I said, man, this is complicated and complex, and I gave him all of those tips that you just mentioned. I think we're going to hopefully probably end up getting him in to see someone at Cedars Sinai in California that's really going to take a deep dive on this congestive heart failure. T-Rob, I'm on with T-Rob. She's hanging with Dr. Cooper. This is Dr. Tara Hrobowski, transplant heart failure expert in Tampa, Florida, good friend of mine, and a lot of you all in Atlanta, because she's been in Atlanta, lived there and worked there at Piedmont Healthcare for a period of time. A lot of women on here, T-Rob. congestive heart failure and during pregnancy. Let's talk a little bit about that. What causes it, and how can women manage that issue during their pregnancy?
So funny, I just had a 31-year-old. I was on call last week and had a 31-year-old flown into me from a surrounding one of our sister hospitals, and it was funny. It freaks the OBGYNs out. Like, oh my God, they were pretty. It was get her out of here though. Like just she ended up doing very well, but again, it's the kind of situation. It's almost like a stress-induced cardiomyopathy. Now, I haven't been blessed to have children, but I can only imagine, physically, the laboring process in and of itself. Is a stressful situation. A lot of women, though, unfortunately, though, in this particular young lady's situation, she had uncontrolled gestational hypertension. And her initial, not the OBGYN that actually delivered her, but the one that was taking care of her during the process, didn't address it. Again, we're back to inertia, right? We're back to that clinical inertia. So that's the way you prevent it from happening, right? Well, you try to prevent it from happening. Sometimes you just can't control it, But after the fact, right, I treat those patients like I would any other patient with heart failure. You're getting on a beta blocker once they're compensated. You're getting on a beta blocker. You're getting, if your kidney function is normal, you're getting on Entresto. You're getting on Aldactone. You're getting on, the SGLT2 inhibitors. You're getting on everything. And you need your tubes out. Period.
Okay, good. So you would not, after an episode of gestational congestive heart failure like that, you would not recommend a second pregnancy?
Absolutely not. I had
That's good information.
In Atlanta, recovered her ejection fraction back to 55-60%. Soon as she got pregnant again.
Wow.
I mean, within a few weeks, 25%.
Wow.
She, when her OBGYN, beautiful girl that was at Piedmont, she was going into labor. She was like, I need you to come now. And while we're in the OR, I'm like, tie those tubes. Do whatever. Snip them, burn them, whatever. Please. She needs to be done. Yeah.
Got it.
Oh, yeah.
No. Yeah. Talk about my OBGYN friends. There's a bunch of them on here. My good friend, Eric Brown. You may know Eric. I think he may have done some work over at Piedmont. But when I was at Crawford Long and I was still at Emory, Eric used to have me come and stand in the delivery room with women who had. I said, Eric, I can't do surgery down here in the delivery room. We got to do this. In fact, we even delivered a couple of babies in the cardiovascular operating room just because Eric was so afraid. And I get it. I mean, the heart can be very intimidating.
For sure. I had an 18-year-old with, I think she had Marfan, so her thoracic aorta was huge. Oh, yeah. And so imagine 18-year-old laboring.
Yeah.
And everybody's freaking out because they're like, please don't dissect, please don't dissect, please don't like.
Yeah.
So I agree. If I were them, I'd want you standing right there too.
That's a big deal. Hey, Carol, both my Carol Hammock and Carol Honea, just lifelong supporters and friends up in Cobb County. Hey, Essence, I see you coming back in. Eric Townsend, Paul Brown, Mildred Lawrence, big sister Mildred, Presto Will. How you doing, bro? I see you. That's Preston. He said, tell me on Instagram to tell you hello, T-Rob. Veronica Burrows, I see you. Christiana up at Wellstar doing her thing. One of my excellent, outstanding CVICU nurses. PBG, Patrice Brown Greer, I see you. Hey, so I'm on with T-Rob. She's hanging with Dr. Cooper. We are going to, we talked about pregnancy and heart failure. We talked about heart failure in general. We talked about COVID and heart failure. Talk a little bit about just give us a little perspective on, I know one of the things that you do and you spend a lot of time doing is taking care of people who have had heart transplants. Talk a little bit about that and what can someone expect after a transplant if it comes to that?
So, well, first, before getting a transplant, I mean, it's a really detailed evaluation process. And let's be clear, one of the biggest things or one of the biggest factors of why people get turned down for transplantation, or even, mechanical circulatory devices like durable LVADs, heart pumps, things like that, is they don't have social support.
Mm-hmm.
So don't isolate everybody out your life. Somebody got to like you. Okay. So we're going to call on, honestly, we will call on them and say, because we need to protect our outcomes, right? So we need to make sure there's someone there if you get in trouble, right? That's going to contact me or bring you to the ER or bring you in, So that's one of the things that I really want to hone in on. Like, you really need to make sure you have social support and someone who understands your medical condition. Okay, so going through the transplant process, once you're approved, right, and you're listed, you're going to be seen typically every month, okay, until you're transplanted. And then even after transplantation, I see you every week. I do a biopsy on you every week for the first 4 weeks, then every 2 weeks for 4 times, then every month for 4 times. So you will never get away from your transplant cardiologist. We will be glued together. You divorce your spouse, but you can't divorce me. Okay. So, again, we're protecting our outcomes. So it's close follow-up. We make sure, you're going to be on medications to prevent what we call rejection, because naturally, you have something foreign coming into your body, right? This new heart. So naturally, your body's going to say, oh, I don't know. I don't want this. So it's going to try to reject it. But that's why you'll be on anti-rejection medications throughout the transplant.
Got it. Now, what long term can a transplant patient expect to just be able to get back to kind of a normal life? We know the follow up is very strict and very important, but getting back out there, exercising, walking, kind of just the normal sort of lifestyle that most people live. And obviously, you got to be a lot more careful with your preventive measures as well.
Right, just with the masking, that kind of thing. But again, that's the whole point of all this. Why go through a sternotomy if your quality of life isn't going to be better, right? Right?
Yeah.
You're not going to somebody's chest open just cause, right?
Yes.
So that's the point. And all of my patients, like I told you before, I send everyone to cardiac rehab, whether it's post-transplant, post-LVAD, post-CABG, anything, post any kind of thoracic surgery, they go to cardiac rehab.
Got it.
Make sure the sternum is stable and that kind of thing, but everybody goes to cardiac rehab.
Cool. Excellent. This is a great discussion. This is Hanging with Dr. Cooper, and I am on with my friend T-Rob, AKA Dr. Tara Hrobowski, to all of the professional, elite white coat folks. But anyway, so T-Rob, I think from this conversation, everybody knows why you're a top doc, but tell us why you're a top doc.
I think I don't know about top doc or whatever, but I think
you're a top doc. Absolutely, you're a top doc.
No, but I always, my philosophy is I take care of my patients like I would want somebody to take care of my parents.
Yes.
So I need them to be treated with respect. I need them to be informed whether they like what they're hearing or not. I just need them to be told the truth, and given guidance, Like you said, people are very smart people, but they have to know their options, right?
Right.
So I think that's what would make me a top doc. I would do this for free. You know what I mean? I would honestly do this for free. I don't want to. I don't want to put that out in the.
You gotta get that check now. There's nothing wrong with that check. Nothing wrong with that check. I'll tell you. My wife will tell you. My wife will say, "Hey, you gotta get that check, man."
But again, if there was a situation, where we hit the lottery, I would still go to work every day.
Yeah. Yeah. I mean, isn't that a great thing though, to find your passion through your work and not really have it be work or consider it a quote job, but really just something you enjoy doing. I mean, that's truly a blessing. Like I say, I got my brother, my homeboy, Reverend Pastor Kenneth Ruff from Norfolk, Virginia, checking in. I see you. So T-Rod, we sort of, we went through the heart failure, sort of all these various iterations of it. Anything else you want to tell us? Any take-home messages from all of this?
Make sure you're your own advocate.
Yes.
Ask the questions. Bring a notebook. I always tell my mom, but love her to death. She'll go to the doctor and then she'll call me.
Yeah. Oh, I get that all the time.
I don't know.
Why didn't you ask them? You were there. Hold them accountable.
Yeah, and it'll be like her liver doctor. I'm like, Mama, I'm like right here. My niece asked me about, when she was pregnant. I'm like, here, I don't know. Like I'm a pretty smart girl, but I don't know obstetrics. I don't know that.
Yeah.
So be your own advocate. And it goes back to, this is not. We're not here to be your parents, as a physician. I'm not your parents. We're here to make shared decisions. I present you with the options. You tell me what your goals are, and we see how they come together. And then that's the best thing for you.
Right.
So I couldn't stress that more because unfortunately, there are some terrible doctors out there. Love my colleagues, but there are some, I'm just like, you may have gone to the best medical school ever, but I would never let you touch anybody that I know or love,
And that's real. That's just that's the reality of it. And I tell patients all the time. I mean, they'll come to my office and say, well, so-and-so told me this. And I said, wait a second, let's stop right there. Why didn't you stop right there with that physician if you didn't understand? And let's break that down for you right there on the spot. Now, I know why you do it with me. It's because I'm going to break it down for you the best I can. But I'm going to hold you accountable. And I'm going to say, hey, look, you need to ask that doctor, okay? And, and you need to hold them and hold the healthcare system completely accountable for the information they're giving you.
And I'll tell, my girlfriends, I'm just like, would you go to someone who messed up your hair? Would you go back to
This is true.
Yeah, so like, if I don't trust you cutting my hair, why would I, feel comfortable going to someone who's not providing me with the answers to the keys to longevity? You know what I mean? Like it doesn't make sense. Sometimes I feel like we get in these roles of like, where, oh, it's the doctor. They know better. It's like, no, you know your body,
Yeah, absolutely.
Advocate for yourself.
Right, absolutely. So this is Hanging with Dr. Cooper. We've been on with Dr. Tara Hrobowski. Tara, now you told me you're not one of these social media folks, but let me tell you something. They love you. Let me tell you something. This is the biggest audience I've had leading up to this. They were all over you. So, and I know you're not connected on LinkedIn and all these other social media platforms. So
I'm on LinkedIn. I'm just not.
Okay. So how do people get a hold of you? They love you. I'm looking at the comments over here and want to stay connected with you.
My email. I mean, they can always.
Oh, Lord have mercy. You want an email? Okay.
Yeah,
all right.
email me. I mean, I have old patients that have found me. Believe me.
Okay.
So I'm more than happy to receive an email. I'm more than happy. The only, I guess, social media, and it's not really social media, is LinkedIn. I mean,
yeah.
I don't know how Hrobowskis are all, but you'll be able to find me for sure. So,
ain't no doubt about it. Yeah.
If you want to share my email, I'm more than happy. Happy.
What is it? So where's your practice located? So for those of you all who are interested in trying to connect with Dr. Hrobowski as a patient potentially, again, and I will say this: we're not your doctors. Okay, we're here having a conversation, and you have to be listening in. So anything that you hear on Hanging with Dr. Cooper, this is for the lawyers out there. You need to go to your doctor. Okay, I'm not your doctor. Okay, now some of you out there I probably have operated on or whatever. but that relationship is over. Okay. So you don't take this information to the bank, come back, try to sue us with some frivolous crap. That doesn't bother me, but I just have to say that for my lawyer friends. One of my lawyer friends said, Coop, you need to do a disclaimer. Okay, no problem. There's your disclaimer. All right. So tell us about the practice though, and how we get a hold of you down in Tampa, because there's a bunch of people in here from Florida, as a matter of fact.
Yeah, I get a lot of snowbirds, right? So they'll come here
yeah.
during the winters and things like that. But I'm at Largo Medical Center. It's about 15 to 17 miles from Tampa. Just go on the website, Largo Medical Center, and then it's the HCA hospital. And you can Google advanced heart failure and transplant, and you will find me.
Yeah. So you're down there in Tampa, Bradenton, Sarasota, Largo, Clearwater.
Exactly.
Kind of that whole area. Lakeland is a little bit further to the east, I think. Yeah.
We have, hospital. HCA has hospitals all along, from north. So in the west, so actually we're the only advanced heart failure transplant center in the West Florida division.
Yes.
HCA. So it's a huge deal, to be a part of something I helped start. So we did our first transplant March 19th. So this was in the middle of the pandemic, kicked off. So, it was really, and something that was so terrible, it turned into a blessing for a lot of people. Yeah. So I'm really proud of that I was able to be a part of that. So
that's fantastic. Dr. Hrobowski, T-Rob, thank you so much for hanging with Dr. Cooper this morning. This has been so valuable. Everybody, I'm looking at the comments here, and everybody has really enjoyed the conversation. We try to keep it simple. We try to keep it educational, and we try to keep it fun so that people really understand. And we try to reach out and touch somebody. I hope some young people out here be inspired by seeing you, hearing your story, and looking at you and said, you know what? I could be like her. Some young lady out there, somebody on here will show this to their grandchild or their daughter and say, I want to be like Dr. T-Rob. So, hey, it's great. Go Chiefs. Thank you so much.
Oh, no.
All right. Go Chiefs. Go Chiefs. Come on now. You cannot. You look.
Go, baby. We got the GOAT.
Oh my, yeah, you do have the GOAT. There's no doubt about that. Oh, they're gonna start kicking in now talking about that. But anyway, T-Rob, it's been a fantastic conversation. I thank you so much. And I want to have you back at some point. Let's do this again. This was fun. I really enjoyed it. We got so much more to talk about. We didn't even get into the VAS, the ECMO very much. We didn't get into the defibrillators. We got so much to talk about. We can get into that next time. Yes. Thank you so much, T-Rob. Go Chiefs. I'm going to leave it right there. We're winning 38-34. Done deal. The new GOAT will be crowned today.
Anyway.
Take care, girl. We'll see you. Bye-bye. Be good. Thank you. Bye-bye.